Hi, this is Dr. Michelle Cotty, and today this is going to be a short introduction to medications for depressive disorders. The objectives for this lecture are to identify the drug categories of antidepressant medications, memorize the drugs in each category, and summarize the adverse effects of each drug class. Depressive disorders. Depressive disorders are the leading cause of disability, one of the leading causes in the United States. So when a patient comes in and starts an antidepressant medication, we want to advise them that the medication can take several weeks or more, up to 3 months, before you feel the benefits of it. So imagine if we'll take Prozac, for example. You start 20 milligrams of Prozac, and it takes 3 months to tell how that 20 milligrams works. And then you increase it to 40, and it takes 3 months, and then to 60, and it takes 3 months. If an RX is prescribed conservatively, it could take a very long time before the patient feels the full benefit. So medication compliance needs to be discussed with these individuals. Clients diagnosed with major depressive disorder sometimes need to be hospitalized, and that is due to suicide ideation. Antidepressant medications are classified into several main groups. So we have tricyclic antidepressants, or TCAs, selective serotonin reuptake inhibitors, which are also known as SSRIs, serotonin norepinephrine reuptake inhibitor, or SNRIs, the less prescribed monoamine oxidase inhibitors, or MAOIs, and atypical antidepressants. Here are some tidbits. Antidepressants treat major depressive disorders, but they also can be used for anxiety. They can improve mood, appetite, and sleep. They don't cause dependence, tolerance, or addiction. If a patient has a diagnosis of bipolar, these medications may exacerbate mania. So we want to make sure the patient is on a mood stabilizer first. Older antidepressants are highly lethal, especially with an overdose. The newer ones like SSRIs or SNRIs are much safer. Some induce anticholinergic side effects. Patients may experience dental problems due to dry mouth. So we want to encourage brushing, flossing, dental cleaning, regular checkups, and sugarless gum. If the patient experiences constipation, we recommend increasing dietary fiber and fluids. And again, if this is the wrong medication for a patient and we give them too much serotonin, it can increase suicide. So we want to make sure that we go over black box warnings with patients when they start these medications. So the medications listed here are listed by medication type. So the TCAs, the SSRIs, and the MAOIs are listed on this page. You can see I tried to make little mnemonics to help you remember. So we have Diana T under the TCAs, Spec V under the SSRIs, and PITS under MAOI. So if you're given a name of the medication, you're going to need to identify which medication class it belongs in. SNRIs, there are 3. Effexor, and Pristiq. So venlafaxine, duloxetine, and desvenlafaxine. We have an atypical antidepressant, Bupropion, also called Wellbutrin. And then other antidepressants include Mirtazapine or Remeron, Reboxetine, and Trazodone. MAOIs are not used very often in prescribing today for several reasons, which we are about to learn. They're contraindicated in individuals who are taking SSRIs or TCAs or SNRIs, or clients who have heart failure, cardiovascular, or cerebral vascular disease, or severe renal insufficiency. You would want to be really cautious in using them if the patient was diabetic or had a history of seizure disorders. And when using the transdermal patch, clients who take Tegretol or Trileptal, you wouldn't want to use that because it could increase the blood levels of the MAOI. TCAs. So TCAs block reuptake or norepinephrine and serotonin in the synaptic space, and this intensifies the effects of these neurotransmitters. It's used for depression and also used for neuropathic pain, fibromyalgia, anxiety disorders, and insomnia. Adverse effects include orthostatic hypotension. So you would want to advise the client to change position slowly, monitor their vitals, and avoid dehydration. It can cause anticholinergic effects. So remember, that's can't see, can't pee, can't poop, dry mouth. To minimize these effects, the patient could chew sugarless gum, sip on water, wear sunglasses when outside, eat foods high in fiber, exercise, increase fluid intake, and void just before taking the medication. Most clients take this medication at bedtime because it does make them tired. Make sure they know not to drive if they are really tired. Toxicity results in a cholinergic blockade, and cardiac toxicity is evidenced by dysrhythmias, mental confusion, and agitation, which could be followed by seizures, coma, and possible death. So patients who are really suicidal, this would probably not be the best medication choice for them because it is a lethal medication. You want to limit them to like a 1 week supply of medication. Make sure you get a baseline EKG, monitor vitals, and that they know what the signs of toxicity are. This medication is not great for clients who have seizure disorders because it causes a decreased seizure threshold, and therefore it's contraindicated for these individuals. It can also cause excessive sweating. Most of these are risk category C medication, and you should be really cautious to use this in any clients who have coronary artery disease, diabetes, liver or kidney disorders, respiratory disorders, urinary retention or obstruction, angle closure glaucoma, benign prostatic hypertrophy, or hyperthyroidism. You don't want to take this medication with other antidepressants. If you use another antihistamine, then that could cause more of those anticholinergic effects. You'd want to avoid using with direct-acting sympathomimetics because it can result in increasing both of the medications. And avoid using with alcohol, benzos, opioids, or, like I said again, antihistamines. Now let's talk about SSRIs, or selective serotonin reuptake inhibitors. SSRIs selectively block reuptake of the monoamine neurotransmitter serotonin in the synaptic space, and this intensifies the effects of serotonin. It's used for major depression, obsessive compulsive disorder, bulimia nervosa, premenstrual dysphoric disorders, panic disorders, and PTSD. So side effects of the medication can include sexual dysfunction, so the inability to have an orgasm, the inability to have an erection, or decreased libido. And make sure you tell individuals about this before they start the medication so that they know to talk to you about it if this occurs. SNRI. So SNRIs inhibit serotonin and norepinephrine reuptake, and this increases the amount available for impulse transmission. There's also a minimal amount of dopamine blockage. Adverse Side effects include headache, nausea, agitation, anxiety, sleep disturbance. In older clients, we want to monitor for hyponatremia, monitor the client for weight loss, increase in diastolic blood pressure. Let these patients know not to stop the medication right away. They'll have really bad withdrawal symptoms, and talk to them about possible sexual side effects. Bupropion or Wellbutrin inhibits dopamine uptake, and it's used for depression, sexual side effects of other antidepressants. It aids in the person's ability to quit smoking, so it decreases their urge to smoke, and it can be effective for seasonal depressive disorder. Adverse effects can include headache, dry mouth, GI upset, constipation, increased heart rate, nausea, restlessness, and insomnia. So you want to make sure they're taking it in the morning. Appetite suppression is caused by the medication, so we need to monitor for weight loss. And this medication could cause seizures, especially at higher doses, so it's contraindicated in clients who already have a seizure disorder or a head injury. You also would not want to give this to an individual who has anorexia nervosa or bulimia. It's a pregnancy risk category B medication. So Mirtazapine or Remeron is like Bupropion in the way that it can be taken with other SSRIs and SNRIs. The combination of Effexor in the morning and Remeron at night is known as California rocket fuel. It's supposed to help the patients be really energetic, motivated, and then sleep like a baby at night. So Mirtazapine increases the release of serotonin and norepinephrine, increasing availability for impulse transmission. Its therapeutic uses are for depression, but one of the reasons it's used is because there's less sexual dysfunction. It causes sedation, and it works a lot faster than SSRIs. It works in 2 weeks instead of 3 months. So often you can start this and then start another antidepressant and then eventually wean the individual off of Mirtazapine. Adverse effects include sedation, weight gain, and elevated cholesterol. Reboxetine or Edronax inhibits the reuptake of norepinephrine, which increases the amount of neurotransmitters that are available for impulse transmission. It's used for depression, and its adverse effects include dry mouth, sexual side effects, decreased blood pressure, constipation, urinary hesitancy, or retention. Trazodone is used with other SSRIs and SNRIs also for a sleep aid. It's a moderate selective blockade of serotonin receptors, and its adverse effects include sedation and priapism. Priapism is a medical emergency of a prolonged erection.